Imagine handing over um, like $2,000 to have a doctor draw your blood, spin it at high speeds in a centrifuge, and then, and this is the wild part, inject it directly into your most intimate, sensitive anatomy.
Right, yeah. It sounds intense.
It really does. And all of this is sold on the promise that it will finally help you experience your very first orgasm. I mean, it sounds like science fiction or, extreme biohacking.
It does. But it's actually this booming sector of the medical aesthetics industry right now.
Which is crazy to think about.
It is a massive market. And the procedure you're describing, it's being aggressively advertised to women who are, frankly, desperately looking for an answer to a deeply frustrating problem.
Exactly. Which is why we're dedicating today's deep dive to a highly specific, honestly intimately important question that you, or maybe someone you know, might be quietly wondering about.
Right.
Can this procedure, which is commonly known as the O-shot, actually help if you have literally never had an orgasm?
It's the big question.
It is. So to figure this out, we're looking past the shiny medical spa brochures. We're diving into clinical guidelines from the American Society of Plastic Surgeons, data from the Mayo Clinic and the NHS.
We also have insights from the American Sexual Health Association.
Right. And we're even digging into how governments regulate medical devices. Because our mission today is to separate the marketing hype from the actual biology.
To do that effectively, we have to start by looking at what's actually happening, or I guess what isn't happening, in the body and the mind when a woman cannot reach a climax.
Right. We need to understand the anatomy of anorgasmia.
Exactly. Medically, this falls under a diagnosis called Female Orgasmic Disorder, or FOD.
But reading through the sources we have, there seems to be a really massive distinction between the two main types of this disorder.
Oh, a vital distinction. You have secondary anorgasmia, which happens when a woman loses the ability to climax after a period of being able to do so normally.
Okay, so the baseline was there.
Right. The baseline was established, but something disrupted it. That disruption is usually identifiable, like a new medication, a traumatic life event, or major hormonal transitions like menopause.
Basically, the wiring is there, but a fuse blew somewhere along the line.
Precisely. The other type, however, is primary anorgasmia. And this means a woman has never experienced an orgasm under any circumstances.
Wow. Under any circumstances.
None. Not with a partner, not through self-stimulation, simply never. And for anyone listening who might be dealing with this, the statistics and the clinical data paint a very clear picture.
Yeah, that you're definitely not an anomaly.
Exactly. You are not alone in this.
The numbers are actually staggering.
Huh.
I was reading the largest U.S. study of female sexual dysfunction, and they looked at over 30,000 women. The overall prevalence of female orgasmic disorder is around 21%.
That's 1 in 5 women.
Yeah.
Furthermore, roughly 75 to 80% of women cannot reach orgasm through vaginal penetration alone.
Oh, wow. 80%.
Yes. Only about 30% climax during intercourse without additional clitoral stimulation. So, the idea that the body is just supposed to intuitively know how to do this flawlessly.
It's just a complete myth.
It is a complete myth.
Well, if it's this incredibly common, what is actually blocking the physical response? Because we're talking about a basic biological function, yet for 1 in 5 women, the system just won't fire.
Well, it's not just one thing. The blockers are this really complex web of physical and psychological factors.
Okay, let's start with the physical side.
On the physical side, medications are a massive hurdle. SSRI antidepressants, for example, are notorious for blunting the nervous system's ability to cross that threshold.
Right, they kind of numb everything out.
Exactly. You also have profound fatigue, thyroid dysfunction, or neurological conditions like multiple sclerosis or spinal cord injuries. Those literally physically interrupt the nerve signaling.
I also read that even the hormonal shifts caused by certain birth controls can depress the physical response.
They absolutely can. But the psychological blockers, they seem to be even heavier.
Yeah, the sources mention things like severe relationship mistrust, body image anxiety, and past trauma.
Right.
But there's also a really huge emphasis on cultural and religious upbringings.
Oh, definitely. Think about the messaging many women receive from a very young age. If you're raised with this deeply ingrained, repetitive message that sex is dirty, dangerous, shameful, or purely for procreation.
Your brain just internalizes that.
It internalizes it as a threat. So when you try to engage in intimacy later in life, your brain actively fights your body's arousal because it perceives the act as unsafe.
It's throwing up a firewall.
Exactly. Which brings us to a really fascinating psychological concept highlighted in the NHS guidelines. They call it spectatoring.
Spectatoring, like being a spectator at a game.
Yes. It is one of the most common and honestly most destructive psychological blockers to sexual pleasure. It's a state where a person mentally detaches during intimacy.
So they aren't even really in the moment?
Right. Instead of being present in their body, they hover outside themselves, essentially watching and critiquing their own performance.
Wow.
Yeah.
Like being a harsh theater critic in the audience of your own life? That sounds exhausting.
It is incredibly exhausting. And it's distracting. A woman might be lying there, anxiously monitoring her body, asking herself, am I close? Is it taking too long?
Right. Is my partner getting bored? Is it happening now?
Exactly. All of that.
But how does that mental checklist actually physically stop an orgasm?
Well, it comes down to the nervous system. When you're anxiously monitoring your performance like that, your brain perceives stress.
Yep.
It activates the sympathetic nervous system, which is your fight or flight response. Adrenaline starts pumping.
Oh, I see where this is going.
Right, because sexual arousal and orgasm rely heavily on the parasympathetic nervous system. That's the rest and digest pathway.
So they're complete opposites.
Complete opposites. You simply cannot achieve the deep, vulnerable physical release of an orgasm while your brain is chemically preparing you to fight off a predator or, like, ace a final exam.
That makes total sense. The intense mental monitoring literally kills the biological arousal.
It does.
So the harder you try, the more pressure you apply to reach the goal, the further away the goal gets.
Right. Because you cannot force the parasympathetic nervous system to relax on command.
You just can't will an orgasm into existence.
You really can't.
When you lay out all these massive neurological and psychological roadblocks, it honestly makes total sense why a woman would want to just bypass the brain entirely.
Of course it does.
If the mind is putting up a firewall, why not just focus on upgrading the physical hardware, right?
Yeah.
Which leads us directly to the invention of the O-shot.
Yes. And the history of the O-shot, or the orgasm shot, is a really fascinating look at how medical technology jumps between disciplines.
It wasn't originally for this, right?
No, not at all. It was developed around 2011 by a physician named Dr. Charles Runels. But the core technology he used wasn't new. He utilized platelet-rich plasma, or PRP.
Okay, I've heard of PRP. I've seen it used for hair loss and facials, like those vampire facials that were all over social media.
Exactly. And long before that, it was actually a staple in sports medicine dating back to the 1980s.
Wait, sports medicine?
Yeah. Orthopedic surgeons would draw blood from an injured athlete, isolate the healing factors, and inject them straight into a torn ligament or a damaged knee to dramatically accelerate healing.
So how on earth did we get from a torn ACL to sexual wellness?
Well, Dr. Renals looked at the regenerative power of PRP and theorized it could be used to enhance sexual function and sensitivity.
Interesting.
So he adapted the orthopedic procedure and initially injected the PRP into his girlfriend's clitoris and the anterior vaginal wall. Basically the area commonly referred to as the G-spot.
Okay, the biological mechanism here is just wild to me. Could you break down exactly what the PRP is doing once it's injected into that really sensitive tissue?
Sure. So when you spin the patient's blood in a centrifuge, you're isolating the plasma and the platelets, leaving the red blood cells behind.
Okay.
Now, platelets are the cells in your body that rush to the scene of an injury to clot the blood, right? But they also contain these tiny structures called alpha granules.
And those granules are kind of the payload.
They are the payload. They're packed with growth factors. When you inject this concentrated plasma back into the tissue, those growth factors signal local stem cells to wake up and start multiplying.
Wow.
Yeah, they boost collagen production, which plumps and strengthens the vaginal wall. But most importantly, they trigger a process called angiogenesis.
Angiogenesis.
Yeah.
Which is the formation of brand new blood vessels, right?
Exact.
So it's essentially taking fertilizer from your own yard, concentrating it, and planting it back into the soil to grow a denser, more sensitive root system.
That is a highly accurate way to visualize it, yeah. More blood vessels mean better blood flow. And better blood flow generally translates to increased sensitivity, improved natural lubrication, and theoretically a stronger physical response to stimulation.
Okay, but the clinical reality of getting this quote-unquote fertilizer planted, we need to talk about that.
Yeah.
Because we're dealing with needles in the most highly innervated areas of the human body.
Yeah, that part makes a lot of people nervous, but the procedure itself is relatively fast. It's usually about 30 minutes in office.
Do they numb it first?
Oh, absolutely. First, the provider applies a very strong topical numbing cream. It's usually a compounded mixture known as BLT, cream benzocaine, lidocaine, and tetracaine.
Okay, the heavy hitters of local anesthesia.
You definitely need them. Once the area is aggressively numb, the provider uses a very fine needle to inject the concentrated PRP directly into the clitoral glands and into the tissue just inside the upper vaginal wall.
I mean, I'm looking at the claims from several medical spa websites we reviewed, and they are incredibly bold.
Oh, the marketing is very aggressive.
Yeah, they advertise that patients can resume normal activities, including sex, that exact same day. And they claim the regenerative effects last anywhere from 1 to 3 years.
Right.
But most notably, they are heavily promoting success rates of 80 to 90% for stronger orgasms, increased lubrication, and even curing mild urinary incontinence. And they're charging anywhere from $900 to $2,000 a session for this.
The marketing is incredibly compelling. They position it as a fountain of youth for female intimacy, like this quick mechanical fix for a complex issue.
Which brings me to a massive contradiction in our sources.
Okay, let's hear it.
If we look at the woman with primary anorgasmia, the woman who has never had a climax, if the spas are claiming a 90% success rate, and this shot physically builds new blood vessels, regenerates tissue, ramps up nerve sensitivity, wouldn't this be the ultimate guaranteed fix for a first-timer?
You'd think so.
I mean, you are literally wiring up the hardware.
You would absolutely assume so based on the mechanism. But this is where we really have to look past the med spa marketing and look directly at the clinical guidance from the American Society of Plastic Surgeons.
Because they chimed in on this.
They did, and they provide the definitive reality check for this exact scenario.
And their verdict is?
Their exact official stance is this. While preliminary evidence indicates these shots can enhance the orgasms of some women, in the woman who has never achieved orgasm, they are unlikely to help.
Unlikely to help. That is a hard stop from the ASPS for primary anorgasmia.
A very hard stop.
But why? If the biology of the shot does all these regenerative things, why doesn't it trigger a first-time climax?
Because the O-shot is an enhancer, not an initiator.
Oh, okay.
If a woman has primary anorgasmia, the root cause is almost never a simple lack of local blood vessels or a localized collagen deficiency.
Right, like we were saying earlier.
Exactly. The root cause is usually a lack of mind-body mapping, deeply ingrained psychological blockers, or simply never having learned what type of physical stimulation works for her specific anatomy.
I see. It's like turning up the volume dial on a radio that hasn't actually been tuned to a station yet.
That's a great analogy.
It doesn't matter how powerful the amplifier is, you know. If you aren't locked onto the frequency, turning up the volume just gives you louder static.
Exactly. You cannot amplify a neurological pathway that has never been established.
So it's physically there, but the brain isn't talking to it.
Right. The O-shot might optimize the tissue, but if the brain is still heavily spectatoring the event, or if the parasympathetic nervous system is still blocked by anxiety, those new blood vessels won't magically override the brain's firewall.
Wow. But wait, if the Plastic Surgeons Society says it won't help first-timers, but medical spas across the country are widely selling it for all forms of sexual dysfunction, who is actually regulating this?
It is a bit of a regulatory gray area, honestly.
Because if I walk into a clinic tomorrow and drop $2,000, who is making sure these claims are real?
Well, it comes down to the nature of the treatment. Because the O-shot uses autologous blood, which means it's your own blood being returned to your own body, it doesn't go through the same rigorous multi-year FDA drug approval process that a new pharmaceutical would.
Oh, because it's not a new drug.
Right. You aren't injecting a foreign chemical, so the risk of an allergic reaction or rejection is virtually zero.
So they don't have to prove the drug works, because there is no drug.
Exactly. However, the devices used to process your blood are strictly regulated.
Like the centrifuge machines.
Yes. The specialized centrifuge kits, like the Cellful system, they must be cleared by regulatory bodies. So the FDA in the US or the MHRA in the UK.
But wait, the FDA clearing a centrifuge just means the machine safely separates plasma without contaminating it.
Right.
Proving the machine spins blood safely is very different from proving the injection actually causes an orgasm.
And that is exactly the issue, which is why the American Society of Plastic Surgeons explicitly states in their guidelines that the medical community needs rigorous, peer-reviewed scientific studies to truly understand the clinical effectiveness of the O-shot.
Because right now, what data are we actually looking at?
Right now, a massive portion of the data driving this industry is anecdotal, and it's often funded by the very clinics selling the procedure.
And getting those independent, rigorous studies is traditionally a nightmare. I mean, clinical trials take years, they cost millions, and they're buried in bureaucratic red tape.
They absolutely are. But there is a really fascinating shift happening right now that could change how quickly we get answers for procedures like this.
Oh, really?
Yeah. Our sources highlight recent major clinical trial reforms rolling out in the United Kingdom.
What are they doing?
The UK government is fundamentally changing their regulatory infrastructure to slash that red tape. They are codifying a combined review system into law.
Combined review. How did it work before?
Previously, researchers had to submit applications to an ethics committee, wait for approval, and then submit sequentially to the regulatory agency. It was incredibly inefficient.
So double the waiting.
Exactly. Under the new system, both the ethics and regulatory reviews happen simultaneously. Their goal is to reduce the time it takes to get a trial approved, and the first patient dosed from an average of 250 days down to just 150 days.
That cuts almost 4 months of administrative waiting time out of the process.
It's huge.
But why does this matter for the woman looking at a $2,000 med spa treatment today? Like, how does UK regulation help her?
Because right now, women are spending their life savings on elective, regenerative procedures based on compelling marketing, while the definitive science lags years behind.
Ah, I see.
Pushing for faster, combined regulatory reviews is exactly what the broader global medical field needs. It incentivizes researchers to actually conduct the high-quality, long-term data trials on things like the O-shot.
Because it's not such an administrative nightmare anymore.
Right. It's the only way to move these treatments from anecdotal spa marketing to proven, peer-reviewed science, so patients know exactly what they are buying.
Okay, so while we wait for the clinical trials to catch up and provide some definitive answers, let's talk about the listener who is sitting here feeling incredibly frustrated.
Yes, let's talk about what actually works.
If the ASPS says a needle won't give them their first orgasm, what does the actual evidence-based clinical toolkit look like for primary anorgasmia?
Well, it looks a lot less like a medical procedure and a lot more like a classroom.
Yeah.
The evidence-based solutions from the Mayo Clinic, the American Sexual Health Association, and the NHS, they all point to a behavioral and psychological approach first.
No needles required.
No needles. You have to build the mind-body map before you can optimize it.
Where do they recommend starting?
Step 1 is often practice called directed masturbation. The goal here is entirely about self-education in a zero-pressure environment.
Right.
The NHS actually recommends using a hand mirror to visually identify your own anatomy. It's about taking the time to learn what specific textures, what level of pressure, and what rhythms provide pleasure.
In doing this entirely solo, without a partner present.
Yes, exactly. Remember that statistic from earlier. 80% of women require direct clitoral stimulation to climax.
Right.
If you've never explored your own anatomy, if you don't know exactly where that stimulation needs to be or how it feels best, it is physically impossible to communicate those needs to a partner.
Yeah, that makes perfect sense. You have to write the instruction manual for your own body before you can hand it to someone else to read.
That is a perfect way to phrase it.
But eventually, a partner enters the picture. How do you bridge the gap between solo exploration and partnered intimacy without triggering that intense spectatoring anxiety we talked about?
The clinical recommendation for that transition is a specialized couples therapy technique called sensate focus.
Sensate focus. How does that actually rewire the anxiety?
It works by completely removing the end goal. In sensate focus, a couple agrees to engage in physical touch with a strict, non-negotiable rule.
What's the rule?
Intercourse and orgasm are completely off the table.
Wait, completely?
Completely. You start with non-erotic touch, maybe just massaging a shoulder or tracing an arm. Over weeks, you slowly graduate to more intimate touch.
Wow. So by taking the orgasm off the table entirely, you're just bypassing the brain's threat response.
Exactly. You are bypassing the amygdala. The brain no longer views the touch as a high-stakes performance review.
Because there's no test to pass.
Right. It doesn't need to trigger the sympathetic nervous system, so the anxiety just melts away. It slowly rebuilds the brain's association with partnered touch from performance pressure back to safe pleasure.
It's an incredible paradox, honestly.
Yeah.
The absolute most effective, clinically proven way to achieve an orgasm for the very first time is to completely stop trying to have one.
You have to unlearn the pressure.
That is wild.
It is. And alongside that psychological unwinding, there are physical tools to support the process. The sources strongly recommend Kegel exercises, flexing and strengthening the pelvic floor muscles.
See, I always thought Kegels were just for bladder control.
They are excellent for that, but mechanically, actively flexing those muscles draws increased blood flow to the pelvic region.
Oh, which is basically similar to what the O-shot attempts to do chemically.
Exactly. But more importantly, it forces the brain to actively focus on the physical sensations in the pelvis, which strengthens that mind-body neural connection.
Okay, that makes a lot of sense.
And if the psychological blockers are deeply rooted in trauma or strict cultural messaging, cognitive behavioral therapy or CBT, along with specialized psychosexual counseling, those are highly effective at identifying and dismantling those roadblocks.
So you really have to treat the entire system. Because like you said, the brain really is the largest sex organ in the body.
It absolutely is.
Let's pull all of this together for you, listening at home. The O-shot utilizes some genuinely fascinating regenerative science. I mean, the mechanism of harnessing your own platelets to stimulate angiogenesis and tissue growth is a marvel of modern medicine.
It is incredible science.
And if you're dealing with secondary anorgasmia, a loss of natural lubrication, mild urinary incontinence, or you just want to enhance the orgasms you already easily achieve, there is growing clinical interest that this might be a valuable tool for you.
But if you are dealing with primary anorgasmia, if you have never experienced a climax, the consensus from major medical bodies is clear.
Right.
Your best investment is not a $2,000 needle. Your best investment is time. It's communication, solo exploration, and potentially psychosexual therapy to map those neurological pathways for the very first time.
And looking at all this data leaves us with one final, deeply provocative thought to consider.
Oh, I like where this is going.
We established earlier that the ultimate enemy of reaching a climax is spectatoring, right? Yeah. That intense performance anxiety, the pressure to achieve the goal, watching yourself and desperately waiting for the biological response to happen.
It is the ultimate arousal killer.
So think about the psychology of the O-shot for a first-timer. If you spend $2,000 on a highly clinical, medicalized injection specifically designed and marketed to force your body to orgasm,
Oh, wow.
does that financial and medical investment actually increase your psychological pressure to perform?
It almost certainly does.
By turning pleasure into a high-priced medical intervention, could you inadvertently be making the spectatoring worse, pushing that elusive first orgasm even further out of reach?
It is a profound paradox. When we hyper-medicalize pleasure, we risk raising the stakes so high that the deep, vulnerable relaxation required for an orgasm becomes completely impossible.
Exactly. Sometimes the hardware is perfectly fine. You just need to learn how to safely navigate the software.
Well said.
Thank you so much for joining us on this deep dive. Keep asking hard questions, keep exploring your health, and we will catch you on the next one.